Good afternoon, ladies and gentlemen. Today we're going to talk about metabolic syndrome. What is it? It's a cluster of metabolic abnormalities, including hypertension, central adiposity, insulin resistance, and atherogenic dyslipidemia. It's strongly associated with increased risk for type 2 diabetes mellitus and atherosclerotic and non-atherosclerotic cardiovascular diseases. The pathogenesis involves both genetic and acquired factors that results in a final pathway of inflammation leading to the development of cardiovascular diseases. Or it's also known as cardiovascular dysmetabolism or cardiobesity or cardiodiabetes, and it's 3 times more common than diabetes mellitus itself. The prevalence: 1 in 3, so each third adult person worldwide suffers from metabolic syndrome. About risk factors: it's family predisposition, gene, obesity, sleep apnea, chronic high-risk food choices, sedentary lifestyle, hypertension, preeclampsia and anamnesis, lower birth weight, and belonging to the following ethnic groups: Hispanic and South Asian. On this slide, you can see the variety of genes involved in the pathogenesis of metabolic syndrome and as well with the type 2 diabetes mellitus. And you see the genes responsible for body mass index, for waist circumference, and fasting insulin level, glucose, and the development of type 2 diabetes. About the cardiovascular pathology in metabolic syndrome: it includes arterial hypertension, atherogenesis, thrombogenesis, myocardial lipotoxicity, and glucotoxicity. About the mechanisms of arterial hypertension development in patients with metabolic syndrome: it includes sodium and water retention in kidneys, activation of sympathetic nervous system, activation of renin-angiotensin system, blood vessels, smooth muscle cell proliferation, and inhibition of sodium-potassium ATPase and calcium-magnesium ATPase, and other mechanisms suspected to be involved in the process: the increase of endothelin levels, an increase of blood vessel sensitivity to corticosteroids, and inhibition of L-arginine and O-cyclic guanine monophosphate system activity. The pathogenic mechanisms of the development of atherosclerosis in these patients. It's a stimulation of blood vessels, smooth muscle cell migration and proliferation, stimulation of cholesterol and lipid synthesis in blood vessels, smooth muscle cells, and maybe the most important, systemic lipid metabolism disorders. What pattern of dysmetabolism of lipids is typical for the metabolic syndrome, or in other words, for insulin resistance? It's increase of triglycerides levels, increase of very low density lipoproteins, and decrease of high-density lipoprotein cholesterol, including decrease of HDL2 levels, decrease of ApoA1 levels, and increase of cholesterol transfer protein activity. Again, about you see the schematic presentation of pathogenesis, including with the central role of lipids, of visceral fat and its lipolysis, and factors predisposing to the abnormalities of the metabolism of visceral fat tissue, including genetic and epigenetic programming and lifestyle and diet changes. And the variety of different biologically active factors, adipokines and cytokines and growth factors, resulting in the development of type 2 diabetes, hepatic steatosis, and two factors, atherogenic dyslipidemia and endothelial dysfunction and hypertension, resulting in the development of atherosclerosis. And beside that, I would like to remind you that this is an inflammatory, so-called low-grade inflammatory process, low-grade inflammation, and prothrombotic state, causing the development of the thrombosis, a variety of thrombotic events in coronary arteries, in central nervous system circulation, peripheral arteries, and etc. In this picture, you can see the role of visceral adipokines in metabolic syndrome. And again, you see the central role of adipose tissue producing a variety of different factors, each of which cause different pathological events. For example, vascular disorders, fibrinolysis, inflammation and insulin resistance, Browning thermogenesis, etc., etc. So about the diagnostic criteria for metabolic syndrome. First of all, and the presence of this pathology is mandatory. It's obligatory part of metabolic syndrome, the presence of abdominal obesity. Plus, any two of following: increase level of triglycerides, decrease level of HDL cholesterol, increased blood pressure, and increase of plasma glucose, or the overt diabetes, type 2 diabetes mellitus. So we can make a diagnosis of metabolic syndrome if we have a combination of obligatory present abdominal obesity plus any two of these criteria. And about abdominal obesity, the diagnostic criteria, it's based on the waist circumference, and you see the measurement criteria for men and women for different ethnic groups. Or another option, if our patient's body mass index exceeds 30 kg per square meter, we can diagnose the presence of abdominal obesity regardless to the waist circumference. On this picture, you see how does it work and how do we measure the waist circumference in male and in female. It's pretty easy, you see. Well, if to talk about the treatment of metabolic syndrome, general approach, first of all, its primary activities aimed at the reduction of body weight, physical activity optimization, and diet correction. Treatment priorities. First of all, we have to identify the presence of metabolic syndrome early. Promote weight loss. Then we treat dyslipidemia if present, treat hypertension if present, treat hyperglycemia and insulin resistance. And if about to talk about inflammation, it's a separate part of this. And reducing, we have to remember that reducing metabolic syndrome biomarkers reduce the incidence of major atherosclerotic events. About weight loss. Weight loss. First of all, it's supposed to be the lifestyle interventions, targeted diets and eating plans, and increased physical activity. If to talk about anti-obesity medications, we have some options. Talking about drug therapy, including phentermine or orlistat, naltrexone HCl, bupropion. Phentermine topiramate or liraglutide, and surgery, so-called bariatric surgery. And how does it work? It works on glycemic intolerance, on microbiome. It improves gut incretin responses and reduces cardiovascular risk biomarkers of metabolic syndrome. Major food pointers for patients with metabolic syndrome. First of all, you should recommend your patients to avoid a lot of saturated fat and refined sugars, highly processed carbohydrates in late evening. You have to add fiber into the diet of your patient. Reduce fructose intake. Reduce carbohydrate intake. Reduce food activities. Reduce food additives, and have to recommend the red wine with resveratrol beneficial. About coffee, I have to recommend the restriction of the coffee in consumption, and 2-3 cups causes 38 reduction in liver fibrosis. Other dietary pointers for weight loss. Tolerance is key no matter the diet and portion control. Then, phenotype matters, and calorie restriction is most effective. The faster you start to lose weight, and the greater the adherence to treatment regimen. Then you have to recommend cycle dieting and meal replacement with sufficient protein and fiber. And as you see, controlled cycled ketogenic diet helps weight loss and may help the stem cell regeneration. But it's not known if it helps to reduce the amount of visceral fat. About exercise. What is suggested currently? Endurance training, just intensity and as needed and tolerated. Usually we recommend to our patients aerobic exercise 3-5 days per week, work up to 150 minutes per week, and continuous or intermittent aerobic activity for 20 to 60 minutes. Then resistance training, flexibility training, and all This can improve the cardiopulmonary oxygen utilization and improves insulin sensitivity. Some facts how testifying to the effectiveness of normalization of body mass, and we see that in the absence of obesity-associated diseases, the reduction of body mass at 5, the reduction of 5 kilograms and more of body mass causes 50% reduction of the incidence of type 2 diabetes, and reduction of body mass for 9 kilograms and more causes 25% reduction of coronary artery disease, and what is more important, 25% reduction of the total mortality. And in case of type 2 diabetes, the life expectancy increased by 3-4 months per 1 kilogram of body weight loss. In the presence of obesity-associated diseases, the loss of 5 to 9 kilograms of body weight causes 20% reduction of total mortality, 44% reduction of mortality caused by diabetes, and 9% reduction of mortality from coronary artery disease. How do we treat the underlying cardiovascular risks? First of all, we have to manage hypertension to achieve blood pressure goals. We manage dyslipidemia to achieve the lipids goals. Usually we use statins or high-dose omega-3 fatty acids. If needed, we have to consider antiplatelet therapy. Do cardiovascular workup and look for microalbuminuria. And of course, we have to tell our patients about the necessity of the smoking cessation. Well, let's go to the treatment of different parts of metabolic syndrome. And treatment of dyslipidemia includes usually statins or omega-3 polyunsaturated fatty acids or fibrates, and as a possibility, the use of other drugs and their combinations if needed. This slide, you see the target levels of lipids in patients with a type 2 diabetes mellitus regarding to the different levels of cardiovascular risk. And if to talk about the target of low density lipoprotein, LDL cholesterol, you see if the risk is cardiovascular risk, is moderate, the level is less than 2.6 millimole per liter. If the patient is at high risk, so your target is supposed to be less than 1.8. If the patient is in a very high risk group, so the target is less than 1.4. About the treatment, first of all, it's statins. It's a first choice lipid lowering treatment in these patients, and the administration of statins is based on the cardiovascular risk profile of the patient, considering the target levels of LDL cholesterol. If the target level of LDL cholesterol is not reached, we have to consider the combination of statin with ezetimibe. If patient is in very high risk group and with a persistent high LDL cholesterol level despite treatment with maximal tolerated dose of statin, and in combination with ezetimibe or in patient with statin intolerance, so we have to recommend the use of PCSK9 inhibitor. Then continue with the treatment of dyslipidemia. We have to think about lifestyle intervention with a focus on weight reduction and the decrease of the consumption of carbohydrates and alcohol. What else? Statins should be considered in patients with type 1 diabetes mellitus at high cardiovascular risk, irrespective to the baseline LDL cholesterol level. They also may be considered in asymptomatic patients with type 1 diabetes beyond the age of 30, over 30 years of age. And statins, we have to note that statins are not recommended in women with childbearing potential. About treatment of hypertension. First of all, we have to start our antihypertensive treatment in patients with metabolic syndrome with the inhibitors of renin-angiotensin-aldosterone system, namely ACE inhibitors, angiotensin II receptor blockers. Or, if not effective enough, if we fail to reach the target levels of blood pressure, we have to consider use of other drugs and combinations. On this slide, you can see the recommended blood pressure targets for different categories of patients, and look at the plus diabetes mellitus. So the target range for systolic blood pressure is from 120 to 130, and diastolic lower than 80. Again, more detailed about the treatment targets for blood pressure in patients with metabolic syndrome, including the presence of diabetes and prediabetes. So the antihypertensive drug treatment, if it's recommended, if office blood pressure is over 100, is more than 140 or 190. In patients, the same goal ranging from 120 to 130 for systolic blood pressure, and target range for diastolic from 80 to 70. Again, the lifestyle changes, of course, including weight loss, physical activity, alcohol restriction, sodium restriction, and increased consumption of fruits and vegetables. And of course, low-fat dairy products. Again, I repeat that the treatment should be initiated with a combination of renin-angiotensin aldosterone system blockers and with it in combination, if not effective, with calcium channel blockers or thiazide-like diuretics. And patients with a pre-diabetic states, impaired glucose tolerance or impaired fasting glucose, renin-angiotensin aldosterone system blockers should be preferred to reduce the risk, preferred to beta blockers or diuretics to reduce the risk of new onset diabetes. And again, what else? The effects of glucagon-like peptide 1 and sodium glucose receptor agonists and sodium glucose cotransporter inhibitors should be considered. About the monitoring, very important is the home blood pressure self-monitoring, and it should be considered in patients with diabetes mellitus on receiving antihypertensive drugs, and to make sure that blood pressure is appropriately controlled. And 24 hours blood pressure monitoring should be considered to assess the abnormal 24 hours blood pressure patterns and to have a chance, to have an opportunity to adjust antihypertensive treatment. About the treatment of diabetes itself, screening. If we screen diabetes mellitus patients with or without atherosclerotic cardiovascular disease, assessment of alkated hemoglobin or fasting blood glucose should be considered. About lifestyle changes, these should include smoking cessation, low saturated fat, high fiber diet, aerobic physical activity, and strength training. And a reduction in energy intake is recommended in patients to help achieve lower body weight and to prevent slow body weight gain. Again, about lifestyle. For those motivated to try considerable weight loss with use of low-calorie diets followed by food reintroduction and weight maintenance phase early after diagnosis can lead to diabetes mellitus remission and should be considered. About glycemic target. The target level of hemoglobin A1C, or in other words, glycated, not the term we use, glycated hemoglobin, and the target for it for the reduction of cardiovascular risk and microvascular complications of diabetes is less than 7% for the majority of adults, regardless to the type of diabetes, if it's type 1 or type 2. Again, about the glycemic control, glycemia targets, and a target of, we're talking again about hemoglobin A1C, a target of 6.5% and lower should be considered at diagnosis or early in the course of type 2 diabetes in persons who are not frail and do not have atherosclerotic cardiovascular disease. About the treatment and what is important, the metformin is recommended as a first-line therapy, and following evaluation of renal function in the majority of patients without previous atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure. In persons with type 2 diabetes mellitus with acute atherosclerotic cardiovascular disease, metformin should be considered unless contraindicated. And we should consider the avoidance of hyperglycemia and excessive weight gain in the patients receiving metformin. In persons with type 2 diabetes and atherosclerotic cardiovascular disease, the use of glucagon-like peptide 1 receptor agonists or sodium glucose cotransporter inhibitors with the proven outcome benefits is recommended to reduce cardiovascular and cardiorenal outcomes. In patients with type 2 diabetes mellitus, the use of this group of drugs, the same groups of drugs, proven outcome benefits may be considered, whether proven outcome benefits may be considered to reduce cardiovascular disease, development of future cardiovascular disease, and the mortality, total mortality and cardiovascular mortality. In patients with type 2 diabetes and chronic kidney disease, the use of sodium glucose cotransporter inhibitors is recommended to improve atherosclerotic cardiovascular disease and cardiorenal outcomes. Again, about the patients with type 2 diabetes and chronic heart failure. And if it's heart failure with reduced ejection fraction, the use of the sodium glucose cotransporter inhibitor with proven outcome benefits is recommended to lessen heart failure hospitalizations and cardiovascular death. In patients with diabetes type 2 but without atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease, the use of these two groups of drugs, sodium glucose cotransporter inhibitors and glucagon-like peptide 1 receptor agonists, should be considered based on estimated future risks for adverse cardiovascular disease or cardiorenal outcomes, risk factor profiles. Again, to summarize the treatment of hyperglycemia and insulin resistance in patients with metabolic syndrome. What drugs can improve the insulin sensitivity and thereby to reduce the hyperglycemia? First of all, it's metformin, then the group of thiazolidinones or glitazones, or other drugs and their combinations. More detailed about the treatment of insulin resistance and hyperglycemia. About metformin. It affects the biomarkers of metabolic syndrome. It decreases hepatic glucogenolysis and decreases insulin resistance. It reduces gut glucose absorption and may work on the microbiome. And you see the other groups of the drugs which can be effective in the treatment of insulin resistance and hyperglycemia in the patients with metabolic syndrome. And about the effectiveness of metformin in this cohort of patients. And look how effective it is in the treatment of overweight subjects, reducing the risk of all diabetic complications by 32%, mortality from diabetes by 42%, myocardial incidence of myocardial infarction by 39%, and total mortality by 36%. And on this slide, we have to see the general concept of the treatment algorithm in patients with a type 2 diabetes mellitus and atherosclerotic cardiovascular disease, or having high or very high cardiovascular risk. If we start with metformin, what are we supposed to do then? If patient has no cardiovascular risk, very high cardiovascular risk, or the presence of atherosclerotic cardiovascular disease, we continue metformin or add other groups of anti-diabetic drugs, and the choice should be based on the level of hemoglobin A1C assessment and on the fact can we achieve the target level of it or not. We can use dipeptidyl peptidase 4 inhibitors, glucagon-like peptide 1 receptor agonists, or tazidinones or sodium glucose cotransporter inhibitors. If these cardiovascular diseases or are present or patient is in a very high cardiovascular risk group, we have to add from the very beginning the sodium glucose cotransporter inhibitor or glucagon-like peptide 1 receptor agonist. That's all. Thank you very much and have a good day.